Okay, so now the recording is on. Remember, these procedures we have already covered during our routine class of the upper limb, but still we are repeating a few procedures that is important. So in CIPS examination, there are 1 hour for the practical examination, and there are four parts of the body that include spine, peripheral nerves, musculoskeletal joints, and the musculoskeletal soft tissues. And among those, there are five procedures in each segment. And from each segment, you have to perform one procedure, and that is on the cadaver. So, here, one thing I should always suggest if you are going for the CIPS examination, do a cadaveric workshop because it is very important. Because what we see in the normal patient sometimes may be difficult to see in cadaver. In US, cadavers are comparatively better, but in other countries, they may not be as fresh as US. So there are plus minuses, but these are the, I have red marked the upper limb procedures. For example, in the peripheral nerves, we have two nerves from the upper limb. One is the suprascapular nerve, the other one is the ulnar nerve at the cubital tunnel. In the musculoskeletal joints, we have two areas in the upper limb. One is the acromioclavicular joint, another is the glenohumeral joint. Here they have noted that any approach is good. That is whether you are doing an anterior approach or posterior approach, it doesn't matter. So while doing the examination, I should suggest you go for the posterior approach because that's the most standard and comparatively easier approach. And in cadaver, it is the bony structures that is seen better because the vessels and other things that may not be that much clearly visible. And the needle position will be comparatively easier if you go for the posterior approach. Then comes to the musculoskeletal soft tissue that includes the peritendinous injection of biceps. This is one of the procedures that we very commonly do because what happens either because of the fluid in the joint or sometimes peritendinitis or tenosynovitis, there are fluid, so we have to inject in a number of cases, so it is very commonly done procedure as well. Then we have the subacromial and subdeltoid bursa injection, again very commonly done procedures. Then we have the medial and lateral epicondyle tendon sheath injection or fenestration. Here you in FIPP you can choose any one, either medial or lateral. But again here I will suggest you go for the lateral epicondyle because it is more common and you will be seeing more patients and it will be easier for you as well. So let's start with the peripheral nerve blocks. We are having the suprascapular and ulnar nerve at the cubital tunnel. I am going into detail later. Then we have the musculoskeletal joint, that is the acromioclavicular joint injection and the glenohumeral joint injection. And we have the musculoskeletal soft tissue injections, biceps tendon, peritendinous injection, subdeltoid bursa injection, medial and lateral epicondylitis tendon sheath injection or fenestration. So let's come one by one. So first we'll starting with the suprascapular nerve block. The anatomy of the suprascapular nerve, I think you can all remember starting from the C5, then coming to the posterior, coming under the this ligament that is known as the transverse scapular ligament. So there is a ligament which is the transverse scapular ligament under which the suprascapular nerve comes. Then one motor branch is given to the supraspinatus tendon. Then the main nerve continues into the spinoglenoid notch from where it goes and supplies the infraspinatus and then in the from the spinoglenoid notch, a lateral branch goes and supplies into the joint. Now it is important because there are some indications in which we do the suprascapular nerve block. So what are those indications? First, chronic shoulder pain because of rotator cuff tendinopathy, adhesive capsulitis or glenohumeral arthritis. Basically to control the pain, we can do this block. Then we have the perioperative pain for the shoulder surgery like the arthroscopy or the rotator cuff repair. Post uh, surgery for the pain relief, it can be done, though as a pain physician we are not doing it routinely. Then comes for this indication, then comes to the shoulder pain due to the cervical radiculopathy. For some referred pain component it could be beneficial, but remember it is also not a main indication for the suprascapular nerve block. Rather another indication is very important, is sometimes might happen though it is rare. It is known as the suprascapular neuralgia, where there is pain, especially in the backpack carriers, soldiers, so they can suffer this condition. And definitely diagnostic block to confirm the suprascapular nerve or suprascapular nerve mediated pain or suprascapular nerve as a carrier or the source of pain. So these are the indications for the suprascapular nerve block. Contraindications definitely include the local infection, allergy to the injected coagulopathy, distorted anatomy, and in some cases, if there are severe pulmonary compromise, especially if that is the only lung and which side you are doing and the other side is severely compromised, then you should be very careful, because definitely there are chances you might go into the pleura. You can accidentally go for the phenylphrenic nerve block, and if that is the only lung on which the patient is breathing, then it could be dangerous. So these are the contraindications for the suprascapular nerve block. Anatomy, I have already discussed. So the patient position, what is the preferred position? Definitely for the operator, it is better to have the patient in sitting position. But we should suggest in most of the cases, you should go prefer the lateral decubitus position, because here one of the advantage is that what happens in a number of cases that we found in patients, the patients undergoes vasovagal. So in those cases, if the patient is sitting, it is comparatively difficult to manage, whereas the patient is supine or in lateral decubitus position or in prone position, then it is comparatively easier. So lateral decubitus you should be preferring for doing this procedure, and definitely the arm resting comfortably on lap or pillow and expose the posterior shoulder region. Now, ultrasound probe placement. So, what probe we will be using? We will be using preferably the linear probe, and usually 6 to 13 megahertz. Too much high power probe, that is 20 megahertz, 22 megahertz, is not very good at this reason, because it is comparatively deeper. So, we did a moderate, something between 8 to 10 megahertz is good enough. Now, place the transducer parallel to the superior to the spine of the scapula. So usually we put over the spine, then we move the probe above and we get to the suprascapular fossa. So what we want to get is a bony break underneath. Okay, and slide laterally to visualize the suprascapular notch and suprascapular artery. Sometimes it takes color, but it is not possible every time to take color. And especially when you are doing in the CIPS examination, there is no chance of getting any color because it is a cadaver. So you have to rely on the bony break, and sometimes you might be able to see the transverse scapular ligament. So these are the main guide for us for going for this block. Now, what are the structures you have to identify? First of all, we have to identify the scapular spine from which we'll be starting. Then we have to identify the suprascapular muscle. So you can see the suprascapular muscle, and sometimes the central tendon of it is also visible. And above, we have the trapezius muscle, and below we have to see the transverse scapular ligament, and underneath you can get the suprascapular nerve and suprascapular artery. Usually artery remains above the nerve. Okay, and artery can sometimes be confirmed with the Doppler, but every time it is not possible because it is comparatively deep and sometimes it doesn't take the color. Now coming to the needle insertion. Now lateral to medial or medial to lateral, you can choose any approach, but usually the medial to lateral approach is comparatively preferred, and you go and you just go close to the nerve, advance the needle under the real-time guidance at the floor of the suprascapular fossa close to the nerve and artery, and try to avoid the vascular puncture. Then local anesthetic injection, usually 5 to 10 ml of fluid is good enough. Sometimes you can add a steroid, especially in case of chronic cases. Okay, and observe the spread beneath the supraspinatus muscle around the nerve. So that is the technique that we employ. So here what we are expecting analgesia over the posterior, superior and lateral aspect of the shoulder region. Duration depends on the agent used, like the which local anesthetic you are using, and definitely steroid effect usually comes between 3 to 7 days. And remember, it is not the definitive procedure for an adhesive capsulitis, because here our main target is for the temporary pain relief, and the patient is able to do the exercise, and ultimately that will comparatively break those adhesions. So remember, sometimes some feel that this is a injection that is good for adhesive capsulitis. It is definitely helpful in a short term, but it is not a long term solution. For that, better you go for the hydrodissection of the shoulder. That will also come across within today's class. And tips. So one of the thing in live patients definitely use the color Doppler, but in FIBP there are no chance of that, or CIPS examination. Then the nerve lies deeper to the artery and near the suprascapular notch under the supraspinatus fossa. So Dr. Roy will be showing the procedure and the volunteer. Any questions? Because remember, today's it is your turn to talk, not my turn or our turn. Okay, we are just repeating the same thing and most important parts and most commonly done procedures. That is why they are chosen for the CIPS examination. So probably these procedures will be doing regularly as well, and in patients also. And if you are going for the examination, then also you have to know this. But remember, if you are planning for the CIPS or FIBB, one thing is very important. You practice at least a year what they recommend before going for the examination, because what is important is the practical skill and it is a one day match. So sometimes on that day you are very good, you have done perfectly, then you will pass. But the chance is more if you are very acquainted to doing the procedures. And also I should suggest not only in the patients, but also you should take at least one cadaveric workshop, because in cadaver the anatomy is slightly different than the normal patients, even with the flesh cadaver. Chinmada, please. So any questions? No questions. Right.
So I will show the suprascapular nerve. Already you have seen that how the suprascapular nerve is seen, but still we are just recapitulating the same thing. So here, first step is patient is in sitting position and his hand is in the neutral position. Okay, so though he can do some internal rotation so that this part becomes stretched, and then I'm putting the probe. This is a linear probe just over the scapular spine. I am audible, clearly.
Yes,
Voice
sir,
is
you're
a
Hello.
little
audible.
less, but it is audible. So can you increase the volume? I do not know if your microphone is slightly reduced in volume or not. That is for me, but everyone please say,
Okay.
is it audible clearly? Dr. Roy's
Okay.
voice is clear, audible
Now
clearly or not?
I now I think it's okay. Okay. So patient, I mean volunteer is sitting in sitting position. I will palpate the scapular spine, and I will put the linear probe in a transverse manner in this way over the scapular spine. So I will, if I go left side is the lateral side. On this screen, left side is the lateral side and right side is the medial side. Most of the procedures will be done in a inline axis. This is the in plane axis, in plane procedure, and then this needle, it will be a bit steep. So the projection, I mean angle of the needle will be a bit steep, so it is a bit difficult to see, and our needle entry will be in the medial side, so from medial to lateral. Okay, and now where we will put the what structures we are seeing. So at this point we are seeing two muscles, one is trapezius and one is supraspinatus. Okay, if I go a bit laterally, then I can see that this is the acromion, and here two muscles, this is the trapezius and this is the supraspinatus. So below supraspinatus there has to be the bony margin. So this part, this is the bone, so this depends on the angulation, that how I can see that there is a gap, the suprascapular notch is seen if how I have put the probe. So some this angulation, if I make it a bit angulated in the upper I mean I do not keep it in a 90-degree position. If I keep it in a 90-degree position, then most of the time I will see only the bony margin. But as I am slanting it a bit, then I will be able to see the vessel and the nerves. So so here we can see the vessels very clearly. Okay, so this is the vessel. So this is the suprascapular. So it takes the color. So I think everyone can see, though it is not taking the color very clearly, but you can see, I feel. So this is the artery. So remember the artery of suprascapular artery, this is usually seen over the transverse scapular ligament, and just below the ligament will be the nerve and vein. Okay. If it is a deep structure, then this structure is not that clear. If in a superficial plane only we can see, but in a deep structure we cannot see better than that. So this is the picture. Okay, so here I freeze it. So remember, this structure, this is the transverse scapular ligament. I expect the needle to come from the medial side to here. So this injection will be, this is below the ligament, transverse scapular ligament. This is the transverse scapular ligament. So my needle will go below the transverse scapular ligament, and also you can infiltrate above the transverse scapular ligament, because there are nearly 4 types of variations has been seen. So sometimes though the commonest variation is below the transverse scapular ligament, you will see the nerve and vein, and just above the transverse scapular ligament, you will see the accompanying suprascapular artery. Okay, and here this is the supraspinatus, and this is the trapezius. Okay, this side is lateral, this side is medial. Any question here?
Sir, if you cannot see the artery using color Doppler, should we use power Doppler instead?
See, this is whenever, I mean, every time this color, it doesn't take the color. It is due to the angulation. Okay, color Doppler you can use. Of course, we will always use the color Doppler to see, but most of the time we can see the artery pulsating, but color it doesn't take. So see, you can see
In
the,
power
this is
Doppler
the
also
artery.
sometimes
We
the
can
same thing happens, huh? You can try giving power Doppler, but sometimes it doesn't show in the power Doppler as well.
It is the angulation, due to the angulation,
Now it
because
is
color
taking.
Doppler has a formula, no, that 90-degree cos 90 is 0, or I mean there is a formula that at 90-degree you will not see the color.
But
So
now
this
it is
one,
taking. Now it is taking the color.
yeah. So you can see this is the suprascapular artery. And so we can see the transverse scapular ligament even. So this one was the transverse scapular ligament. Okay, so this two lines
Uh,
here you can see. So
uh,
this is the transverse
can you
scapular
draw the
ligament.
needle path?
Needle path, yes, of course. Just a minute. Yes. So here, okay. So with this picture, I will go from the medial to lateral direction. This is the needle insertion from medial to lateral. Okay. This is the transverse scapular ligament, and this side is lateral, this side is medial. Understood?
When we can block the nerve at the spinoglenoid notch.
Uh,
Spinoglenoid. Yeah, Dr. Devjyoti will answer. Same thing
uh,
actually.
it's a
Yeah.
very good question because this question comes to my mind. Why this is required to block at this point? So let me first share a picture because the anatomy, once you understand, then the reason why spinoglenoid will be very much easy. So just let me show you the slide. So see, the nerve is like this. Okay. So here is the nerve. Now, when we are doing only local anesthetic steroid block, no issues. It is not causing any motor component loss. So it will not be causing any weakness of the nerve. If you are doing a pulse radio frequency at the suprascapular notch, no issues because that is also not going to, it's a neuromodulation. It is not going to block the motor component. But if you are planning for a cooled radio frequency or a conventional radio frequency at this point, then what will happen? This will actually block the supply of the supraspinatus as well as it will block the supply of the infraspinatus. So there will be muscular weakness because of the nerve blocking at the supraspinatus and infraspinatus. So if you are going for a chronic shoulder pain and if you are thinking to denervate the shoulder, in that case, you go at this point and then block close to the acetabulum near the sphenoglenoid notch, where already the supraspinatus and infraspinatus supply is given. So that is the advantage of blocking at this point. So preferred procedure here is the cooled radio frequency. Because cooled radio frequency, the lesion size is comparatively larger. It is usually 4 to 5 times larger than the conventional radio frequency, as well as it is not dependent on the direction of the needle, because what happens in conventional radio frequency, the lesion comes from the sides, whereas in cooled radio frequency the lesion is circular and it goes beyond the tip. That is why at this point we should go for the cooled radio frequency when we want a cross shoulder denervation for the chronic shoulder pain. Understood?
Yes, doctor, thank you. But both the nerves at the two sides, we can block it for chronic shoulder pain.
See, if you are planning for neuromodulation or steroid local anesthetic block, then this position is good enough because that is not going to do any motor impairment. But if you are planning for the radiofrequency ablation, then definitely this is the place to be done.
And actually, if there is an entrapment neuropathy at this site, suprascapular notch, I mean supraspinatus notch, specifically you can see that there is an entrapment neuropathy at this point for any reason. So in that case, you will go here only.
Yes, that is also thing. Sometimes there could be a cyst compressing, then you can also aspirate the cyst. So there are multiple reasons by which this nerve can be compressed.
Can we block the nerve in both sides at the same time?
No, in that case, if it is the pathology is here, then there is blocking at this point will not be helpful. For example, if there is a compression at this point, then there is no point of blocking here. Okay. So if there is
Yeah,
an entrapment neuropathy here, so in that case, the hydrodissection should be done at this point.
I mean, it's if the indication for the block is for the pain only, for the chronic shoulder pain.
Then usually, if you are planning for a steroid local anesthetic block, at this point going is very easy. So then usually people prefer going for this block only for the temporary relief. In that case, there is no need to go for the sphenoglenoid notch. Okay, because it's the proximal area. If you block at this point, the steroid local anesthetic block, it will be blocking both the muscular components, but as it is a steroid local anesthetic block, it usually do not hampers the motor component. So in that case, the neuritis component will be comparatively treated, as well as there is a membrane stabilizing effect of the steroid that will help to reduce the pain. In that case, going at this point is not essential.
Okay, doctor, thank you.
Okay, so Chinmata, do you have anything to show, or now you should go to the next part?
No, next part.
Next part, okay, fine. So next one is also very common just after the carpal tunnel. The next is the cubital tunnel. That means the most common compression in the upper limb is at the carpal tunnel, and the next is the cubital tunnel in the ulnar nerve. So what are the indications? Ulnar neuropathy or the entrapment of the ulnar nerve at the elbow, or sometimes this is also known as the cubital tunnel syndrome. Then chronic pain in the ulnar nerve distribution, that is basically maybe because of the entrapment neuropathy or maybe because of the some inflammation or repeated dislocation. So there is a pain in the medial part of the forearm and the fourth and fifth fingers. Then post-operative analgesia. Sometimes ulnar nerve block can be done. Here in chronic pain, we don't do that, but definitely that's an indication. And diagnostic block, if we are suspecting there is a neuropathic pain, and for the localization, we can go for a diagnostic block. Contraindications is a similar local infection, coagulopathy, severe ulnar nerve injury, distorted anatomy, as well as the allergy to the injected components. Now here also the preferred position is supine or sitting, but again in all upper limb procedures, though it seems very simple while sitting, doing it also easy, but be careful, especially if the patient is aged and chance of vasovagal, because I personally encountered that many times and sometimes it becomes very difficult. So I prefer nowadays only supine position. So keep the arm abducted and elbow flexed at 90 degree and forearm externally rotated. Okay, palm facing up. Place a small towel under the elbow to support. Now ultrasound probe, here we should use a high frequency probe, usually 10 to 15 megahertz. If you want a higher frequency, that is better because this area is very superficial. So you can go up to 20 or 20 megahertz probe to see the nerve very clearly, and clearly honeycomb appearance can be seen with the high frequency probe. Place the transducer transversely. So basically what you have to do, I always say, here one side it is the medial epicondyle, other side it's the olecranon. With the probe, just try to bridge the two bony prominences. So once you are putting the probe over the bony prominences and using an ample amount of gel, especially if the patient is lean and thin, use a little more gel because sometimes this area is depressed, so it should be covered by the gel. And identify the bony landmarks. So medial epicondyle and olecranon. These are the two bony landmarks that you have to identify and find which side your index marker is. Then it will be very easy because if you want to see, you can put the index marker towards the medial epicondyle, and in that case, definitely that left side of the screen will be the medial epicondyle, right side of the screen will be the olecranon, and you will be able to see the ulnar nerve at this point. It is usually hypoechoic and above the ulnar collateral ligament, okay, and within the carpal tunnel, and above there is also a fibrous structure, and that is known as the Osborne's fascia, okay. So it will remain superficial to the ulnar collateral ligament and beneath the fascia of the flexor carpi ulnaris as well as the Osborne's fascia. So here you can see the ulnar nerve. Above we can see the Osborne fascia, or sometimes it is also known as the Osborne's ligament. And here is the posterior band of the ulnar collateral ligament. And here it's the olecranon, and his side is the medial epicondyle. So if there are any cause that is compressing the nerve been found, that we have to look for and search. For example, if there is a cyst or any inflammation or a bony fracture as well, or an osteophyte in aged patient, so that could be the source of the compression at this area. So ulnar nerve looks like the oval or honeycomb. Sometimes remember, as we are seeing in the background of a ligament, then what happens? The ulnar nerve sometimes can be seen very hypoechoic at this point. Not only this type of honeycomb pattern every time will be seen. Then we have to find out to body contour, and we have to find out the ulnar artery which lies anterior and medial and which remains outside the cubital tunnel. Okay, so it is not within the cubital tunnel. Needle insertion is usually in plane, and technique is usually medial to lateral, but lateral to medial can also be done. So it depends on how you are doing it, and then advance the needle under the direct ultrasound guidance towards the ulnar nerve, staying superficial with the nerve sheath, and direct and avoid direct intraneural injection. So basically, like all entrapment neuropathies, here first we have to go just above the ulnar nerve, then we have to make a fluid layer there by gradually doing the hydrodissection, and then we have to come below and do the hydrodissection below. And after a negative aspiration, inject local anesthetic, and usually we mix with 10 to 20 milligram of local steroid, and usually 3 to 5 ml with circumferential spread around the nerve. Sometimes we call it the halo sign, and that should be made, and that is the procedure we are completing. So Chinmaya, can you please show that? Are you there? Yes. Am I audible?
Yes, yes.
Okay, but your voice is not there. Okay.
Mm.
Please show the ulnar cubital tunnel.
Okay. So, okay, I think I am audible, isn't it?
Yes, audible.
Okay. So, ulnar nerve. A bit difficult to focus in this area. Okay. So here we can palpate two parts of the volunteer. So one is your olecranon. Olecranon is here, and one side is your medial epicondyle. So this medial epicondyle and olecranon, these two parts we can palpate. So now to see the ulnar nerve, first we will see in short axis. Okay. So in short axis, first I will put the ultrasound probe in a transverse manner, and I will put one end over the medial epicondyle and one end over the olecranon. So here in this way, if I put, so I know that left side is the medial epicondyle because I have put my probe in that way. So left side is medial epicondyle and right side is olecranon. So let me make it a bit clear. Yes. Okay, so if I decrease the depth a bit. So I know that the nerve which is near the medial epicondyle, which has to be near the medial epicondyle. So I will search the nerve near the medial epicondyle and not near the olecranon. So here actually I have to use the depth. Wait, I'm not being able to demonstrate well because, okay. So this is the picture. In this position, it will be better. Okay. So in this position, I can show you. This is the medial epicondyle. This is the ulnar nerve, and this side is the olecranon. And in between, this is the joint space. Okay. This is the joint space, and this is the olecranon. Okay. Let me show you. Just freeze it. So this side is medial epicondyle. This side is olecranon. Olecranon. This is the joint space. I will always search for the nerve in this portion. It is just behind the medial epicondyle. So this is the cubital tunnel area. This is just behind the medial epicondyle, and this is the ulnar nerve. This is the ulnar nerve. Okay. So what are the other things I can see in this picture? So this part, this part, this part. What is this? Anyone can say what is this? This part?
Um, ulnar collateral ligament.
Yes, posterior part of the ulnar collateral ligament. Here, one small Osborne's ligament should be there. It is there, of course, but to see Osborne's ligament clearly, your probe should be a bit more high frequency probe you need. That's why we are not seeing the Osborne's ligament here very nicely. So please. Video wonderful. Anyway, here Osborne's ligament is not very clean, but this okay. Yes. So this white part is the Osborne's ligament. Here it is the ulnar nerve, and lower part, this is the ulnar collateral ligament. Okay. Now we will see this nerve only in a long axis manner. So it is in the middle part. I have kept it in the most middle part. So now if I make it in a long axis view, sorry, this not staying in the, this is common because keeping it in the right position in the cubital fossa is a bit tough. So this black, this hypoechoic nerve we can see. Let's see. So this, why we need to see this in a long axis? Because if there is a completion and some part has become thicker, then we will be able to see in a long axis view. Actually, a short probe is needed for this, hockey stick probe or at least high frequency probe is needed. And here actually the footprint of this probe is a bit quite big, so I'm not being able to place it in the cubital fossa. Okay, so so this is a long axis view. This is the long axis view of the ulnar nerve. Though it is a bit distal. So this is upper part, it is the proximal side ulnar nerve. Left side, I am going proximal. So this is the ulnar nerve. Yes. So this part, this is the ulnar nerve. This is the proximal. This is the long axis view. So for ulnar nerve compression, if you suspect a ulnar nerve compression or cubital tunnel syndrome, ulnar nerve neuropathy, then we should see the cross-sectional area of ulnar nerve proximal to the cubital tunnel and distal to the cubital tunnel. So that cross-sectional area is measured in a in this short axis manner, not in a long axis manner. So here, say this part, when I am seeing the ulnar nerve in a long axis, in a short axis manner. So this is the ulnar nerve. So I am going a bit more proximally. I am going a bit more proximally here. So here you can see this is the cross-sectional area. This part we can measure the cross-sectional area proximally of the ulnar nerve. And when I come distally, then I can see the cross-sectional area of ulnar nerve in this area. So not too much distal, but just distal to the cubital tunnel, means area of compression. So this is one cross-sectional area. In this area I can measure, and then I can go proximal and I can measure in this area. Okay, so it is before the, if the proximal cross-sectional area is more than the distal cross-sectional area of ulnar nerve, then it supports the diagnosis of ulnar nerve compression neuropathy at cubital tunnel. Okay, so this is one thing. Second thing is this one, for dynamic examination, there is a possibility of subluxation of ulnar nerve in the cubital tunnel. So how do we see that test? So here we can see. So this is the ulnar nerve is staying in the within the cubital tunnel. So in this view, I will make his elbow extended. I will keep this elbow in extended position, and then I will flex. Then I will flex it, and I will see that whether it crosses the bone or not. So after flexing also, I can see that it is going above the bone, but it is not going out. And again, it is coming in the right position. So it is not a case of ulnar nerve subluxation. Okay. Okay. So you understood this part?
Can you repeat, doctor, regarding the proximal and distal difference, the cross-sectional areas of ulnar nerve, please?
Okay. Let me check a bit. Let him rotate a bit, otherwise it doesn't show clearly. Okay. Okay. So here you can see it is just about a compression of any nerve actually. Whenever we see compression of any nerve, there can be proximal to the compression, nerve becomes thicker before the compression, and distal to the compression, nerve becomes thinner if there is any compression. So when I am seeing the medial epicondyle and olecranon, so I am seeing the cubital tunnel area. So this is the cubital tunnel area. Now I will go a bit proximal and I will measure. So this is the area which is a bit proximal to the cubital tunnel. So here I will measure the cross section of this ulnar nerve in this area. I will see the cross section of ulnar nerve, and then again I am coming here and I am going just below the cubital tunnel. So here also again I will measure the cross section of the ulnar nerve. So if there is a gross difference between these two cross sections, then we can think of a this is a corroborative evidence. I am not saying that this is 100% evidence. There are many electrophysiological tests also. The NCB also should be positive, but this is a corroborative evidence that there may be a compression within the cubital tunnel. Okay.
So can you show us how to inject over the cubital tunnel? Should how's the approach of our needle?
Needle placement. Okay. Needle placement, see here in this view only. In this view, you can come from, okay, just a minute. So here. So your needle can come from this side to this side. So just perineural. This is a perineural injection. Okay. So in this way only you can put the your needle, you can put here, and you can give the local anesthetic or steroid or 5% dextrose for hydrodissection of the nerve. Understood? Here you can see that this is depth is very less, so you can see the complete needle under the ultrasound. Yeah, so this one is the nerve clearly, so I think there is no confusion here. So here this is the nerve, honeycomb appearance, you can see. So this is outside the cubital tunnel, this is outside the cubital tunnel, this is inside the cubital tunnel, this is proximal to cubital tunnel. So we'll measure the cross section in the proximal and distal whenever we will think of a cubital tunnel syndrome and compression, mainly compression related changes. Okay. So understood now this part?
Yes, sir.
Okay.
Okay, let's move to the just 1 second.
তোর হাত পড়ে যাচ্ছে ঘুমাতে ঘুমাতে, এত অসুবিধা মানে কি রে মানে
Mada, please mute. Okay. So next part is the acromioclavicular joint injection, which is comparatively much simpler, but it is because it is very superficial. But sometimes putting the needle becomes a little bit difficult, because especially in inline view, if it is inflamed and degenerative, then it is comparatively easy to go in plane. But in cases where it is not that inflamed, but still there are degenerations and inflammation, in those cases sometimes you have to go out of plane. Anyway, let's start with the acromioclavicular joint injection. So what are the indications? First of all, acromioclavicular joint arthritis, which is actually more common than the glenohumeral joint arthritis, post-traumatic acromioclavicular joint pain, degenerative or inflammatory AC joint disease. For example, patients with rheumatoid arthritis sometimes have inflammatory acromioclavicular joint arthritis, persistent localized tenderness at the acromioclavicular joint, not responding with the conservative management, and diagnostic block to differentiate other type of pain from the acromioclavicular joint pain. Contraindications are similar, like the infection, allergy, coagulopathy, fracture, instability, and suspected septic arthritis. Then in that case, definitely we can go for the aspiration and culture, but we will not be going for the steroid injection for sure. Then coming to the patient position, preferred position is sitting, because you have to go from the top. And remember, this is a very important tip, that whenever you are going to the acromioclavicular joint, don't search it from the anterior side, search it from the top, then it is comparatively easily found and easily you can get it. And shoulder should be relaxed and slightly adducted. And acromioclavicular joint is that you have to find out in between the clavicle and the acromion, and it is usually palpable easily, and then put it from the top. Transducer is usually 10 to 15 megahertz. You can take an higher as well, and place the probe in short axis orientation directly over the acromioclavicular joint line, and identify the distal part of the clavicle, the lateral part of the acromion, acromioclavicular joint space between these two, and the joint capsule, especially the superior joint recess, can be easily found out. So here it's an inflamed joint, so you can easily see the superior joint recess and find out the bony landmarks joint space capsule overlying structures like the deltotrapezoidal fascia superficial to the capsule. Avoid small vascular branches from the thoracoacromial artery, though they are very small arteries, not seen in all the cases. Now, needle insertion, if possible in plane, then definitely go for the in plane. But if I have already told, if joint is not that inflamed or it is not that bulged, then sometimes it is very difficult. In that case, you have to go for the out of plane approach and insert the needle superiorly, directing downwards into the joint space and advance carefully until the tip lies between the clavicle and acromion. If you are going out of plane approach, then we try to find out as a point and within the joint line. So that is very important. And first do an aspiration, and if it is negative, then you inject the local anesthetic and therapeutic mixture, usually the lignocaine as well as a corticosteroid triamcinolone 20 to 40 milligram is good enough, and won't be able to give much volume here. Usually 1 to 1.5 ml is the maximum volume that we'll be able to inject, and you check the capsular distension after injecting it. Okay, so after that you have to complete the procedure, and expected effect, definitely there will be reduction of pain, which is very significant in case of acromioclavicular joint, and long-term improvement usually starts, the steroid effect starts between 3 to 7 days, and the improvement lasts up to 1 to 2 months, and sometimes it may needs to be repeated. And definitely during this period, evaluate the shoulder properly. The improved shoulder elevation will be there, and cross body adduction will be possible because of the reduction of the pain. And few important tips: joint space is very small, use a smaller and shorter needle. If the joint space is severely degenerated, needle entry may feel firm. So sometimes because of the calcification, you might have to push a little, and you need to inject slowly under the visualization, and always confirm the intra-articular spread by real-time observing the needle tip. In both the cases, whether you are going in plane or out of plane, in the outer plane, the technique is come slightly away from where you are able to see the needle as a dot, and you will understand the tip, because within the joint you have to, your tip should vanish as well. That means go to and fro, that is anterior and posterior slightly, and check the needle tip should be within the joint. So that is the basic thing. So Chinmada will show it. It is very simple procedure. Acromioclavicular joint injection.
Oh, okay, so I think you all can see his shoulder. So I'll go for the acromioclavicular joint uh, intervention for showing it. Just a minute. Okay, so here you can do the intervention in plane approach, out of plane approach, and in short axis, in long axis. In all the approaches are written in book. So here thing is that and sometimes in some patients, when the anatomy over the skin, there is it is not straight. If it is not straight, then you can use the gel, a lot of gel. So gel standoff can be used in this area. So here I will just put the probe from above, and it is just straight. I have not palpated also. So this is the straight area. I am just put from above. Now left side is the acromial side. Now I will increase the depth a bit. Okay. So okay. So this is the long axis. I'm seeing the AC joint in a long axis manner. So this part this is the acromion bone. This is the clavicle. I can understand that. I already know that this is lateral side and this side is medial side. Okay. So this side is medial side and this side is lateral side, and this part is joint. This part is AC joint capsule. Here also we can see sometimes one hypoechoic shadow. When this USG goes in, we can see some part here also. So what is this? This is supraspinatus muscle. Okay, supraspinatus muscle, of course, that will be covered by the SASD bursa also. So here in this view, we can go for inline technique. In inline technique, so how we will go? I just show you either. So as I told you, in plane technique, out of the plane technique, and both views, everything can be done. So here, say I want to do an in plane technique. So I will put the AC joint in this area. Just a minute. Okay. So here what I am doing a gel standoff. This part is gel standoff. Okay. That's why I'm seeing this extra layer. Why I am doing this? So that I get some extra space for a very superficial injection. So in this view, I can put the probe here and I can go from here. So this will be a inline technique in a for injection in this AC joint. Okay, in plane technique. This is a in plane technique in a long axis view. And if you want to go for a out of plane technique, then of course the needle will come like this. So that will be out of plane technique, straight, just by the side of the needle you can go straight here. For out of plane technique, of course, you do not need this gel standoff. Okay, so this gel standoff is needed only when you are planning for in plane technique. Otherwise, there is very less space for in plane technique. Okay, so this is one thing. When we are holding the probe in a long axis manner, and if I put the probe in a short axis manner, then you do not need any gel standoff and all. So this is the joint, and what we can do is, just a minute. So in just in the middle part, so when I have kept the joint in the middle, so here I can go for a long axis, a short axis manner. So here I can see if I come in this side, so this is the last ending of the clavicle. Okay, now this part is joint and this part is again acromion. This is acromion, this is joint, and this is the clavicle. So in this view also you can go for the intervention. Okay, so what I will do, I can keep it like this. Okay. So here it is the joint only and nothing else. So I have to put the injection from behind. From behind, I can put the injection, and the injection can come from here to here. So this is the joint space directly. Okay. So both the, but most commonly what we do is in a, when we see the joint in a long axis manner and we go just out of the plane. So I will hold the probe in this way and just I will go out of the plane. It is not even 1 centimeter. So I will go here. The needle will go straight here and we can inject the drug. So is there any confusion here? Or you
Yes,
have understood? Yes,
the
tell me.
other, the clavicle and the acromion,
Yes.
the long axis, it's not clear.
This one is long axis. This picture is of long axis. If you short axis is like short axis is nothing like you want to see short axis, you are seeing that one.
Yes.
So see, this one is the joint, this one is the joint, left side, right side. So I will keep it in just in the middle part. I will in the middle part I have kept and just I am making it rotation movement from the long axis to, from the short axis to long axis. Now this is the way I am holding it inside the, this is the joint space. If I go a bit on the, oh, this picture is like, okay, okay, if I put it, if I move it just towards the clavicle, I can see the ending of clavicle, bony ending of clavicle. I am going laterally, this is the joint, and just I am going a bit more laterally, this is the starting of acromion. So you can hold in this area, you can hold in this area and you can put your injection from the posterior side or anterior side even, and you can enter inside the joint. That's it. So you can bring it in this in one corner and you can put the needle inside. So this is a very superficial joint and it is a very easy injection. Okay.
So how deep should we inject so that we don't inject into the SSD bursa?
I could not understand your question. Please come again.
How deep should we insert the needle into the joint? How deep does it go so that we don't accidentally inject into the supraspinatus?
Oh, no, supraspinatus, for supraspinatus needle is you need a bit bigger needle. When we are using only that 3 centimeter needle which comes with 5 cc syringe, that will not reach at that depth. Okay, so you can see clearly that you see the
But
depth.
Shirma, the supraspinatus is already there. That is also a part of the examination because this
Yeah.
MIPP, because we have the subacromial sublutal bursa. So we'll be seeing that
No, no,
time
no,
actually.
no, no. He's asking a bit different thing. That here, this is the joint. This is the joint here, and supraspinatus is here in this area. This area. Okay. So when you are putting the needle, so up to this much is say 1.5 centimeter or 1 centimeter like that. But if you think that you will go up to this much, then you do not need, I mean, you need a much longer needle. This small needle will not reach.
Thanks, sir.
Okay.
Hmm.
Yeah.
Okay, let's go to the next part. That is the ultrasound guided glenohumeral joint. So GH injection, here we are discussing only the posterior approach because it is more easier to do in cadaver definitely. So indications, definitely the adhesive capsulitis, either diagnostic or therapeutic, we'll be doing the hydrodissection there. Glenohumeral joint arthritis, for the management of pain, we can go for the intra-articular steroid injection. Inflammatory arthritis or post-traumatic arthritis like rheumatoid arthritis or post-injury pain because of the glenohumeral joint inflammation, in that case we can do. Chronic shoulder pain which is not responding of the conservative therapy, there we can go for it. Post-operative shoulder stiffness after the rotator cuff repair, then it can be done. Diagnostic intra-articular injection to differentiate the glenohumeral pathology from the periarticular disorders. Contraindications are similar. I am not going to repeat it again and again. Now coming to the patient position, here also it is preferable to do it under sitting, but definitely In lying down position, especially in the prone or lateral position also it can be done, and especially if the patient is aged, be careful, and in that case either lying down or prone or lateral decubitus will be the better position. Arms should be relaxed and placed on the lap by hanging on the side, and operator should be behind the patient if the patient is sitting, and shoulder should be in neutral rotation position. Use a high frequency linear transducer. Try to find out the supraspinatus notch, then the joint, and also the cartilage. Okay, so these are the things that this picture we have to get. So basically this is the bony glenoid, and here we can see the cartilage, and in this portion we can see the cartilage over the humerus, and this is the deltoid and this is the infraspinatus, and in this area we have to go just lateral to the labrum and close to the cartilage. This area is usual site for the injection. So landmarks, we have to find out the humeral head, rounded hyperechoic contour the lateral side, and we will be getting the glenoidal rim, we will be getting the joint capsule, infraspinatus tendon, posterior portion of the labrum, and the joint space appears as a narrow hypoechoic gap between the glenoid and the humeral head, and we have to enter from the lateral to medial side, and in this area we have to reach. Needle insertion is in plane and lateral to medial approach. Insert the needle from the posterior aspect just inferior to the scapular line. Advance under the continuous ultrasound guidance and target the area between the labrum and the humeral head. Remember not to prick too much on the cartilage, and because it sometimes can be painful, and contact the bone confirms the proximity to the joint. Avoid the suprascapular and the circumflex suprascapular vessels. Use color Doppler if required. Okay, and injection, after the negative injection, if you are going to only steroid injection and local anesthetic injection, usually a small volume between 3 to 5 ml is good enough, and 40 milligram corticosteroid is injected. If you are planning for hydrodilatation, then a volume of 20 to 40 ml is usually required. First inject 4 to 5 ml of 1% lignocaine, and then inject the normal saline or dextrose, and then you have to go for the steroid if you are using. But if you are using dextrose, then do not use the steroid. If you are using the normal saline and local anesthetic, then you can use the steroid as well. The long term benefit is definitely with the dextrose, but the short term pain relief occurs first with the steroid. And observe for the capsular distension and the fluid space within the joint space under the ultrasound visualization. And what is the expected effect is the immediate pain relief and long-term improvement in the range of motion and the pain, and reduced capsular stiffness in the adhesive capsulitis. And there are a few important tips. Keep the nasal needle trajectory parallel with the probe to maintain the continuous visualization. That is very important, not only for this procedure, but for most of all procedures done in the ultrasound. So do not take a short path, take a longer path so that you can take that see the needle clearly. And the posterior approach minimizes the risk of vascular or the neurovascular neural injury. And if the capsule is tight, sometimes in frozen shoulder, inject slowly to prevent the pain or resistance during the injection. So we'll be seeing this now.
So our target is glenohumeral joint, but approach is posterior approach. So what we'll do, so this side is lateral side, this side is medial side, we will just palpate the scapular spine. So as we have palpated the scapular spine, so just below the scapular spine, and I will put the probe in a transverse manner. Okay, so in this way. So here the depth should be a bit high. Depth should be a bit high. And now the left side, left side shows the lateral side. So here when I am seeing the just below the scapular spine, so here what I will do, first I will try to understand that which one is the head, which one is the head of the head of the humerus. So how I will understand the head of the humerus? First thing, let me decrease the focus down. So okay, so to understand the head of the humerus, I will just tell him to do internal and external rotation. So when I see that it's internal and external rotation, I can understand the moving part is the head. Okay, so moving part is the head. So as soon as I can understand which is the head, so other parts also becomes much clearer to me. So let me show you. Okay. Okay. Oh. So other parts also becomes a bit clearer to me. So what are the other parts? Other parts are okay. This is humeral head. This part is glenoid. This part is glenoidal labrum. Okay. This part should be spinoglenoid notch. Spinoglenoid notch. This is the infraspinatus. Whole thing, this is the infraspinatus. And upper part will be trapezius. Upper part will be trapezius. This part is trapezius. This part is infraspinatus. Okay. So our target is between the articular cartilage and the glenoid labrum. We can always inject from the lateral to medial direction. That means our needle will come from this side, lateral to medial direction from here. But which area? It should be between the labrum and the cartilage. So it should be like this. Okay. Now, if we put from here like this, we will not be able to see the joint at the needle at all, because it is a quite steep. So I will take this part here at the side of the screen so that my needle angulation becomes a bit less. So let me show you this part. So this is the, we have understood that which one is the head and which one is the other parts. Okay. So what I will do, I will take it in this way. Okay. Like to move. So you can see this is the head. This is the head. So fix. Okay. So this is the area. I will keep it in one end of the. So it will not be more clear in him. So this much. So I will hold the probe in this way, and I can inject from the opposite side. So now the angulation will be a bit less, so that the needle angulation is like that. Okay. So this is the area for posterior glenohumeral joint injection. Any confusion here? I think you can understand the structures, isn't it? Yes, this is the needle entry point. Okay. And when you inject, the drugs should not be accumulated in this area. Okay. Drug can go just below the infraspinatus. In this area, gradually there can be a fluid collection because this is the recess, posterior joint recess, but it should not be above the muscle. Okay. Any question here? Okay.
Okay, let's continue. So we have 2-3 more procedures left. So next procedure, we have already done the glenohumeral joint from the posterior side. So next part is the biceps. Okay, so biceps, what is done commonly is the peritendinous injection due to bicipital tendonitis or tendinopathy, bicipital groove pain, and bicipital tenosynovitis. And contraindications are similar. I'm not going to repeat. Patient position is supine, sitting or upright, arm resting on the lap or slightly externally rotated and elbow flexed at 90 degree. The position exposes the bicipital groove under the anterior shoulder. High frequency linear probe commonly used. Place the transducer transversely over the anterior shoulder. Find out the bicipital groove in between the lesser and greater tuberosity and find out the long head of the biceps tendon, which appears as a round or hyperechoic fibrillar structure. We can check in the longitudinal view as well. Longitudinal view, biceps look like this, whereas in the cross-sectional view, it looks like this. So landmarks we need to identify is the bicipital groove, then long head of the biceps tendon, then transverse humeral ligament which lies just over it, and deltoid and subcutaneous tissue remaining above. And it is important to find out that the nearby structure should be clear and the fluid around the biceps, if they are present, that indicates actually biceps tenosynovitis. And usually, except for PRP, if you are injecting steroid, you should not inject within the tendon substance to avoid the rupture. Now needle insertion usually in plane lateral to medial and insert parallel to the probe advancing towards the tendon sheath and advance slowly under the real-time ultrasound visualization until the needle tip goes and remains adjacent to the tendon surface. You can also check in the longitudinal view, and remember this procedure can also be possible completely in the longitudinal view. Then it is also not difficult. Sometimes the needle can be seen better under that position, and confirm with the small amount of the saline, that is the hydrodissection, you are close to it. And then after negative aspiration, inject local anesthetic and corticosteroid, that is most commonly done. In case of partial tendon rupture, you can go for the PRP injection as well, and the fluid should be outlining the tendon circumferentially. An expected effect is definitely if the pain relief and the reduction of the tendon sheath inflammation and improved tendon shoulder flexion, and effect usually lasts for week to months with steroid, and for the PRP it could be longer. Ensure the needle tip is outside the tendon fibers. Usually we avoid going inside the tendon. Use colored Doppler to avoid if any small vasculature is present. Hydrodissection with saline can enhance the accuracy, and post procedure usually the patient is asked to take a little bit rest of 24 to 48 hours, and then gradual physiotherapy should be done to prevent the recurrence. Please Chanbada, show it.
Devjyoti,
Yes.
you talk about the next one also. I'll show
I
together.
think yes, so only 2-3 things are left. We do not left with much time, so let us continue and finish then, because these are already we have seen this and these are not things. The last is the not the last, but the one last is remaining. That is the lateral epicondyle. I am covering all three, and then you can show all three together. So subdeltoid subadduct acromial bursa injection. That is another procedure. Here, the indication is a subacromial subdeltoid bursitis, rotator cuff tendinopathy, chronic shoulder pain, adhesive capsulitis, post-operative or post-traumatic bursitis, and diagnostic block to find out this is the pain source. And contraindications are similar, not going to repeat here. For the acromion subdeltoid bursa injection, usually preferred position is sitting or supine. Arm should be relaxed and resting on the lap and internally rotated, and lateral shoulder region below the acromion region should be exposed. Use a high frequency ultrasound probe. Try to find out the acromion as well as the supraspinatus tendon. So when there is SASD bursa inflammation, you will be able to see the fluid in between the SASD bursa just above the supraspinatus tendon and just below the deltoid, and you should identify the following landmarks: deltoid muscle, subdeltoid bursa, supraspinatus tendon, and humeral head. And just above the humeral head you will be finding all these structures. And pseudoanatomy, you get the subacromial and subdeltoid bursa, deltoid muscle, and supraspinatus tendon. And here you should inject just above the supraspinatus tendon. Needle direction is usually lateral to medial. Advance the needle under the continuous ultrasound guidance through the deltoid muscle into the bursal plane and confirm the placement by hydrodissection with a small volume of saline. Injection after negative aspiration, first inject local anesthetic, then you can give 20 to 40 milligram of the steroid at this point, and sometimes you can inject a little bit bupivacaine or lignocaine to increase the effect, and total volume usually 3 to 5 ml, and observe the fluid spread between the deltoid and the supraspinatus. Next, last one is the ultrasound guided lateral epicondylitis, mainly the ECRB injection. Here, both the medial and lateral epicondylitis are there for the CIPS, but lateral epicondylitis is more common. That's why I discussed that part only. So, indication definitely the lateral epicondylitis, mainly which is actually the micro tear or the inflammation of the extensor carpi radialis brevis, and chronic lateral elbow pain, partial thickness tear, and then we have the calcified tendinopathy, and also we can go for the diagnostic injection. Contraindications are similar. Patient position is usually sitting with the elbow flexed at 90 degrees, forearm pronated and the hand relaxed, and expose the lateral elbow. Under the ultrasound probe placement, you just try to put the lateral epicondyle at the uh, with the index marker. So basically, and the rest will be towards the extra common extensor tendon. You will be able to see the lateral epicondyle, common extensor tendon origin, mainly the ECRB, and the extensor digitorum communis, superficial to ECRB. And also we can find out a hypoechoic or irregular area within this tendon, which could be the tendinopathy or microtear. So basically, this is the lateral epicondyle, this is the radiohumeral joint, and the upper portion is the common extensor tendon. Find out this, and if you are injecting the steroid, then inject either at the superficial or deep to the common extensor tendon close to the bone, or if you are injecting the platelet rich plasma, you can inject within it. Also, when you are injecting a steroid, sometimes we say inject within the muscular part but not within the tendinous part. That is the important part. And needle insertion is usually below from the distal to proximal, and there could be two types of insertion. One could be without fenestration, that I have told, around the tendon, then we can inject steroid. And one, if you are going for the dry needling or PRP injection, you can go for first pass of 10 to 15 types, which is actually the tenotomy, and sometimes it will be causing the local bleeding and the fibroblast response, promoting the healing. And usually what is injected, local anesthetic from the seen and scapular tissue, corticosteroid around the tendon, not within the tendon. Alternative biologics or PRP or prolotherapy can also be used. Usually 1 to 2 ml is good enough, don't give too much, and observe around the tendon sheath and within the micro tears. Expected relief, if you are injecting the local anesthetic steroid, then immediate pain relief will be there. If you are planning to give the PRP, initial there could be a little bit increase in pain, or you are doing only the tenotomy, there could be initial increasing in pain, then it reduces and the relief may come in weeks to months, and with PRP, sustained tendon healing and sustained relief is possible. Post-procedural care, I'll ask the patient to rest for 48 hours, and the gradual stretching and eccentric strengthening of the wrist extensor should be done. Avoid gripping or lifting any heavy object within 7 to 10 days. Initially, after the procedure, we give an ice pack to reduce the local soreness and reassess the patients in 4 to 6 weeks. Sometimes a repeat injection may be required. So that was all about the last three procedures. Sachin Mada, can you show all them together?
Yes. So one procedure is for bicipital tendinitis. So how we will see the bicipital tendinitis? So here actually we can look. We should be seeing this bicipital tendon in a long axis view. So this is the bicipital tendon. So here what I am seeing is left side. Left side. It is the joint side. I mean it is cranial side. It is cranial side. And right side it is caudal side. This is the bicipital tendon in the bicipital groove. Okay. So what is the thing that we will see in this view? So we want to see that whether there is any fluid collection around this tendon. A small fluid collection, very less amount, that is actually common. Sometimes in a normal patient also that is possible. So that is acceptable. But if there is a lot of fluid collection here in these areas, then we will say this is a case of bicipital tendinitis. Of course, we will be giving the I mean, we will be applying the colored Doppler also if there is increased vascularity or not, and that part we will compare with the opposite side. So this is for diagnosing the bicipital tendinitis, and for intervention you can come. Of course, intervention we can do in a short axis also, so that will be much easier. So here we can see that in the middle part, this is the biceps tendon. So we can see that whether it is hypoechoic or hyperechoic. So this is due to the anisotropy. This sometimes become hypoechoic, sometimes become hyperechoic. So in this view, we can go for the intervention around the, if we want to give the injection around the biceps tendon, long head of biceps tendon. Of course, while injecting, we should be careful that there can be a artery. So this is an artery. Okay. So in this area, sometimes some artery can be there. Okay. Remnant, some transverse humeral artery can be possible present. So we should not be puncturing that. And so in this view, we can inject from lateral side to this area. If there is a fluid collection, then we will inject there for bicipital tendinitis, treatment for steroid infiltration. Then second procedure is your subacromial bursa, SASD bursa injection. So this is the most common procedure which comes to a pain clinic for impingement syndrome, or say SASD bursitis, or say supraspinatus tendinitis, all these things. So here only thing what we will do, so cross position, modified cross position, nowadays we do not do because it is painful for the patient. So what we can do, we can just extend the shoulder. This much extension is more than enough. Okay. So with this view, we can so here how I have hold it. So what I can see here, I have to decrease the depth a bit. So this is a picture. Yes. So this picture is good enough for intervention. So here what I'm seeing, this side, this is the acromion. This part, it is the humeral head. This part, it is the greater tuberosity. Okay. So where is the tendon? So this is the tendon. This is the supraspinatus tendon, but big appearance of supraspinatus tendon insertion over greater tuberosity. Now, where is your SASD bursa? So SASD bursa, remember a black line within this white line. White means this white part is periversal fat. This part is periversal fat. Okay, these are loose areolar tissue, periversal fat. And this black line, this red line is actually the bursa. So it will be represented as a hypoechoic line. So if it is a patient, then this hypoechoic line will be much bigger. This will be much thicker. Okay, and you can compare with the opposite side. Here it is very small since he is a volunteer. Okay, so how we will go for intervention? Injection will come from this side and it will reach up to this much in this line. Then we can inject the steroid so that it goes inside the SASD bursa. Of course, if so for PRP injection and all, intratendinous, our needle should come here. Okay. So I think there is no confusion here in this part.
So, can we inject with a short axis view instead?
What?
This now you're showing long axis view for the supraspinatus, right?
No, steroid should never be given inside the tendon. Steroid should be given peritendinous, means inside the bursa. But if you are giving PRP for some reason inside the supraspinatus tendon, then you can go inside.
What I mean is the view of the supraspinatus. Can we do at a short axis view?
Short axis
Injection.
we can see, but with short axis we do not inject. This is the short axis view. So
You don't recommend injecting the SSD via short axis view.
short
recommend?
no,
Yeah.
I could not understand your question. Short axis I can show you, but short axis is not for intervention.
Or you don't recommend injecting SSD using short axis view?
No. There is no need. In a long axis view, we are seeing it clearly. So why to go for short axis view? And short axis view, I mean, if there is a fluid collection, of course, in short axis view also it is seen well. But there is no need. I mean, in long axis view, we can do it nicely.
I see. Because I was taught
Sure.
to inject using short axis view.
Yes. So in long axis view only we are always injecting. In short axis view also it is seen, of course, if there is a fluid collection, but we do not inject in short axis view. I will not say that if you inject, then also fluid will go in the right place only. But I have never seen recommendation or anywhere that you have to. Is there any benefit? I don't know. I don't think there is any benefit of injecting in short axis view. Okay.
Thanks, sir. Yeah.
Okay. So this part we have shown. So last one is your last one is tennis elbow injection. Already we all know that lateral elbow, common extensor tendon intervention of lateral elbow. But so Dr. Devjyoti was showing that ECRB tendon. Okay, so remember, so here I am just holding it like this. So here, what are the things we are seeing in this position? So we are seeing this part is epicondyle, this part is condyle, this part is radial head, middle in between this part is joint. So here actually this part is the common extensor tendon, not the lower part. This part is your radial collateral ligament. Okay, so commonly what we can do, we can like imagine one line here, one point here, or one point here. We can make it half. So this half is for ligament, and this half is for common extensor tendon. Okay, so here you see, if so this is the, I can decrease the depth a bit. If you see carefully, there is a gap, though this so here we cannot differentiate between the tendinous, upper part is the tendinous tissue and lower part is the ligamentous tissue. We cannot differentiate that much, but still the upper part here, there is a tendinous, this two lines are there. This is actually tendon of ECRB. If we focus in this area, then I can show you. Let me see in another group. Just a minute. Okay. No, we cannot see this one. Okay, so you can see some fibrillar structure in the upper one. So this part is a bit fibrillar. So this upper fibrillar structure, this is the mainly common extensor tendon contribution from ECRB, this fibrillar structure. If we see in a short axis view, then actually when we come distally like this, we see a scorpion tail appearance. So this scorpion tail appearance, this big scorpion tail you can see. So this scorpion tail appearance is the ECRB tendon. So when I am going again at the insertion point, so this is the ECRB tendon contribution. So if I just from here, I make it in a long axis, then you will be seeing, so this is the ECRB tendon contribution. You can see, so this part is the ECRB tendon contribution. Okay, so it is more often blamed for the common extensor tendon, lateral epicondylitis. So ECRB tendon is more clearly should be seen. So this part, middle part, the main bulk is formed by the ECRB tendon. So anyway, here when in a tennis elbow, if I want to do an intervention, what I will do, so I will see this picture, and my probe will come from this side to this side. So this is the injection. For intervention in this way, we will put the needle. So here either I can come inside the tendon for PRP injection, or my needle will go just above the tendon for peritendinous steroid injection. Okay, I know that common extensor tendon is here. This much is common extensor tendon. So I can put peritendinous injection or inside the tendon if it is PRP. Okay. Any confusion here? Okay then. Rajudit? Okay. So I think nothing more. So we have a quiz for today. Here now. So please join the quiz. It will take only 5 minutes.
House King
Mohammed Taha.
Okay, I'm starting.
Quiz.com. Play and create.
False about
English House
superscapular.
joined.
Motor innervation to the subscapularis. Which is false. Suprascapular artery most commonly runs below STSL, nerve and vein runs over. False about AC joint intra-articular intervention. Gel standoff shouldn't be used as it can impair visualization. Which is wrong. Four equals suprascapular notch. Which is wrong. 2 equals calcorocoacromial lick. Which is false about supraspinatus tendon tear? All full thickness tears are complete tears. Which of the following ultrasound findings is most suggestive of subacromial subdeltoid burn? Anechoic or hypoechoic fluid distension of the bursa exceeding 2 mm. Which of the following is the most consistent USG finding in ulnar neuropathy at the elbow, cubital tunnel syndrome? Focal increase in CSA of the ulnar end proximal to medial epicondyle. Which is not a finding of biceps tendinopathy. Decreased vascularity around or within the tendon.
Final question. Double points.
Which of the following best describes the primary goal of ultrasound-guided hydrodissection of a peripheral nerve? To mechanically separate the nerve from surrounding adhesions.
Third place. Luckamy Farman. Second place. Foolish House. And the winner is Love Street.
Can't hear you. Sorry, can't hear you.